Okay, very good afternoon to all our participants who joined us from across India, Maldives, Nepal, Sri Lanka, and Bhutan. We would like to welcome all of you to this special webinar program that we are conducting today on behalf of Reshe Healthcare and Schulke India Private Limited. We would like you to come to celebrate the International Infection Prevention Week, which is coincidentally happening from October 18th to 24th. Unfortunately, because the next week is the Dasara weekend and the Navratri weekend, so we thought we will slightly prepone it and we will start the celebrations one day earlier over here. So that is the reason why we are doing this. And anyway, a very warm welcome. Today is the start of the Navratri across most parts of India. I'm sure it's a big festival, so we would like you to enjoy this major festival occasion, and also like you to enjoy the upcoming webinar that we have coming up today. So without further delay, I would like to introduce our esteemed speaker for today. This is Dr. Parivallavan Rajavelu, who has a consultant surgeon and a specialist laparoscopic surgeon from Sundaram Medical Foundation in Chennai, and he has over 31 years of experience. He is also credited to setting up the first well-organized emergency department in the private sector in India in Sundaram Medical Foundation, and made it one of the best-known academic emergency medicine centers that are there. He's also worked a lot with diabetic foot. He has worked with IIT Madras to developing diabetic foot, and he developed an equipment called the pedopyrograph to measure the foot pressures, and this is his invention. He's credited for that. He's also the head of the quality assurance team of SMF at Chennai. He's also the CEO of a very new organization called Skills for Med, which is for patient care skills in Chennai. This is an organization that shares best practices with healthcare professionals to equip them to make them a better patient care support. He is also an instructor in the advanced trauma life support system that is there. He is also happened to have published a lot of papers and is also co-authored a lot of textbooks in the field of emergency medicine. So without further ado, and to introduce such a wonderful personality to us, we would like Dr. Parivallavan to take up the screen. And now I'm sharing my screen right now. So over to you, sir. You can start sharing your screen.
Yeah, thank you.
So if you click on that, you should be able to that. You can make it as a full screen. Thank you so much, sir.
Yeah. First, are you able to see my screen?
Yes, sir. We can see your screen. I hope everybody can see the screen. Yeah.
First, apologies for being late. Unfortunately, there's a little bit of a domestic emergency, so I really apologize for the delay in making you people wait. So without any delay, let's get along with the webinar. So here we are going to talk about enhanced surgical safety during the COVID-19 pandemic. Being a surgeon, the initial days of the pandemic, we were all jobless because elective surgeries were off, and people were afraid to come to even emergency surgeries. So from being almost a very busy surgeon by middle of March, suddenly most of the surgeons, and including myself, were jobless. But then as we started to understand the disease, slowly, things got back to normal. And this is where, I started my first emergency in the COVID-19 ward was a patient with a gastric perforation. So now looking back, the first case, we are almost laughing at how we managed it. There was so many slips with all the knowledge now we have. But anyway, most of us managed to get without any infection. But unfortunately, after about 4 or 5 days after the surgery, I actually developed COVID-19 myself. So that really, sort of woke me up. And fortunately that my disease was mild, and I was able to use that 14 days of quarantine very usefully to understand all about the disease and to learn about how to prevent the disease from the healthcare workers. So as I also head the quality assurance team in my hospital, so the quality team took a lead role in putting safety measures both in the theater and hospital wide. So this is something which I wanted to share with you all, because none of us are exempt from the disease. As you know, from Prince Charles to our Home Minister to the famous singer S.P. Balasubramaniam. Everybody, it sees no class or higher or middle or low income group. So prevention is the best strategy. So I have divided my talk into actually 4 major topics. I'll just give an introduction. All of you know about the disease, but just a brief introduction and update of what we know about the disease. Then we'll talk about surgeon safety, patient safety, and OT safety. Usually, we always talk about patient safety first, but I think this pandemic is an exemption where we need to keep ourselves safe first. And that is when we are able to serve the patients better. So I also will touch upon N95 reuse because there's a lot of controversy in that. And then just certain short nuggets about procedures like laparoscopic surgery, orthopedic surgery, just an overview. And finally, I'll end with the challenges and solutions. So the novel coronavirus, as you know, has affected the humans for the first time and has resulted in a pandemic. And people, all our lives we have heard that, united we stand and divided we fall. But now coronavirus has made us reverse this scenario, and we say divided we stand and united we fall. So with this pandemic, what is happening, in October 2020? What do we know about the disease? Actually, not much. We know it spreads via respiratory droplets, but several studies have shown that virus in every organ and body tissue, but its significance in disease spread is not known. Whether the presence of the virus will make it spread is still not known. And we all know the common symptoms of fever, cough, breathing difficulty, and myalgia. But atypical symptom presentation of every organ system, be it cardiovascular or respiratory or neurological, has been reported. So the emergency physicians have a tough job because COVID presents in a myriad number of ways. As of today, there is no proven treatment or vaccine. Now, several candidates are there. There are antivirals, there are steroids. They're all to some extent helpful, but we don't have one particular magic bullet which will cure this disease. And as I said, there is no vaccine. And prevention, is just those 3. Shortened as SMS: sanitize your hands, wear a mask, and keep social distance. This is 3 things are the one which is going to save millions and millions of people, including the healthcare workers. So we need to see, what we can do as surgeons and how we can keep the surgical patient care delivery safe. Now, let's talk about surgeon safety. So when you talk about surgeon safety, the first mantra is protect your face. FACE is actually an acronym which I've coined. And the second is choose an appropriate patient interaction strategy. So what is this FACE? So F stands for face and body protection. So you need to wear a mask, you need to wear a face shield and a gown. So as far as surgery and procedures are concerned, there is no 2 ways about it. You need to wear an N95 mask. And adding a face shield has proven to be of additional benefit. And the gown also has to be worn. The type of gown depends on whether you are operating on a COVID negative patients or a suspected or positive patient. For a negative patient, it's usually the surgical suit, but for a suspected or positive patient, you need to wear the full suit. The A stands for airflow and ventilation. Many times, we forget about this. It has been proven beyond doubt that coronavirus spread happens in closed spaces, whereas in spaces where they are well ventilated, the spread is much less. Therefore, if in a surgical OPD, this is very relevant. So you need to keep those windows open. If you need to have an exhaust which blows the air out into the atmosphere, and more importantly, you need to design your room in such a way that the airflow is from the window and away from you. Most of the time, what the engineers will do is when you ask for an exhaust, they'll come and plug it in your window, and the patient is sitting in front of you, and it actually blows the air from the patient to you if there is an exhaust behind your back. So please don't do that. If you don't have an exhaust like I've shown here, at least put a fan, just behind your seat so that the airflow is away from you. This is very, very important, and in the outpatient setting. Now, the C in the face stands for cleaning and disinfection. Cleaning first, it starts with yourself. Perform hand hygiene as often as possible. Surface cleaning is proven to be the most efficient method of removing this virus. Fogging is actually, CDC is told beyond doubt that fogging is not an effective method of disinfection. And UV light helps to enhance the surface disinfection. On its own, we will talk a little bit more about UV light when you're talking about theaters. But now the basic fact is, one, UV light, there are shadows, so it won't work there. And two, on its own, it's not such a good disinfectant. Along with surface disinfection, if surface disinfection clears the virus by about 60–70%, addition of UV light will get it up to 90%. So it's more of a boost for the surface disinfection, and just relying it on its own may not be a good idea. So that's C. And E in the face stands for engineering controls. So the engineering controls are partition. These are very good, small acrylic or partitions are very can be portable, placed on the table. And when you're consulting with the patient, the patient sits on the other side of this partition, and this also prevents the spread of the virus. The other important thing is the distance. If you have a big enough room, you can actually tape, as I've done in my room. You can see that I have taped it on the floor so that the patient always sits 6 feet away from me. And in our hospital, we have moved all the waiting areas to the outside with huge shamianas, so that they are also safe, so that and it was a bit of difficulty in the summer months, but now with winter, and it's getting better. But in the rainy season comes, we will have one more challenge. But as much as possible, try and keep them in well ventilated places. That's the point. So this is the FACE, sorry. So the face and body protection, the airflow and ventilation, cleaning and disinfection, and engineering controls. So these are the basic 4 aspects which will keep you safe from this virus. So now, patient interaction for surgeons is going to be very difficult. It's very, very difficult. We were probably the late adopters of telemedicine. Surgeons, we need to see the wound. We need to actually touch the patient, palpate the patient, and make a diagnosis. So for that reason, telemedicine was not something which we looked at very seriously. But now we have started using it. Once, for post-op follow-ups, when you know that the wound is fine, and you just want the patient to come back for a wound check, this is perfectly all right to do a telemedicine consultation. And you can also do some remote patient monitoring. Chronic disease management, our medical colleagues are doing it, using this a lot. It can also be used for writing repeat prescriptions for chronic disease like APD and GERD, and they don't need to come to you directly. And also, when you're going to refer patient to some other specialist. So you can use telemedicine and use it appropriately. And of course, face-to-face consultation is still needed when you need that physical examination and to perform procedures. We have to be in direct contact with the patient. So, but what I'm trying to say is we can still minimize the number of patients you actually see face-to-face. So that's about surgeon safety. So now we are going to the surgical patient safety. So here we will talk about patient education and getting the consent, and testing preoperative patients, and how to triage patients for surgery, and what are the best practices in managing a surgical patient. So when you talk about consent, we have to inform the patient that they might face higher postoperative risk. So several studies have shown that when you operate on a COVID positive patients, they do definitely have more pulmonary complications than those who have not been operated. So that is a risk which we have to explain. And also, every patient, whether it's COVID positive or negative, when they come to a hospital, they are at higher risk of contracting the disease in the hospital. So these 2 things have to be clearly mentioned, and you get obtain an informed and special consent. In our hospital, we have a special consent form for the COVID patients and the COVID ward, and for patients who are getting operated in the COVID theater. So this is very, very important. And the next thing is you need to test every patient who's going for surgery. This I think it has become almost mandatory. And but only thing you have to remember is the test can get delayed. So in an emergency, you may not wait for these tests, and therefore, and there is also a chance of getting false negative tests. Now, what is the percentage of false and negative? RT-PCR is the gold standard as of today, but still it has got a 20% false negative rate. That means 1 out of 5 patients may be missed. This is actually a huge number. So as surgeons, I think the best practice would be to treat, in fact, for every patient walking into the hospital, its best practice would be to treat everyone as COVID positive and to take appropriate precautions. So we have, a minimum, in addition to standard precautions, in the COVID pandemic, we have additional precautions which are mandatory in the theater. In addition, we have more strict protocols in the COVID theater. So we are coming now to triaging the patients for surgery. So triaging the patients, we divide the patients into 3 categories. Emergency surgeries are those we need to operate within 24 hours. These are usually trauma or sepsis, which has resulted, acute abdominis has resulted in sepsis where time is critical. So you cannot wait, for the COVID test. Here, these are now designated as emergency patients. Urgent patients still need a surgery in the same admission. They can probably wait for 24 hours. The typical example is appendicitis, where you could waiting for overnight. Even in the pre-COVID eras, it has been proven that you don't need to operate appendix in the midnight. You can wait and take them as the first case in the next operating list. So these type of cases where the surgery can wait for 24 hours is designated as urgent. And elective are those which can plan at a convenient time, both for the surgeon and the patient. So how do we manage these 3 groups? The emergency patient, as it's not possible to wait for the test, you treat all patients as if they are COVID positive. So you admit the patient in the isolation ward, which is the COVID ward, and then you operate the patient also in the COVID ward OT to adhering to all the COVID-19 protocols. So you see in the left, we divided into pre-op, OT, and post-op phases of patient care. And once you operate on the patient, again you shift the patient to the ward. By this time, hopefully, your COVID test will be back. So depending on whether the patient is positive or negative, you would put them in the COVID ward or the normal ward. If the test is not available at the time of recovery of the patient, you still have to take them to the isolation ward. And then once the results are back, then you decide whether they're going to a COVID ward or normal ward. So that's the emergency patient. So urgent patients is quite easy because you know the test results. So it's a COVID positive patient, you admit them to COVID positive ward, COVID positive theater, and then again shift them back to the COVID ward. Whereas a COVID negative patient takes a different route. They go to the normal ward, but you still adhere to the enhanced standard precautions because many patients can be asymptomatic, and 1 in 5 patients can be missed by the RT-PCR. So this is not very difficult. And elective patient, if they are COVID positive, you have to wait. You provide alternatives, give supportive measures because they're it's not emergency or urgency to operate on this patient. Wait for 14 days because operating on COVID patient definitely has a higher risk of morbidity and mortality. So it's not worth taking the risk. So you do it after 14 days. Whereas a COVID negative patients goes like any normal patients before the COVID. So this is how you triage patients into emergency, urgent, and elective, and do the care accordingly. Now we have finished about surgeon safety and also patient safety. Now we will go into operating theater safety. Now you need to have a dedicated theater for COVID patients, preferably in a separate setting or at least a separate wing of the hospital. And you need to strictly define staff responsibilities provide staff safety, ensure appropriate instrument cleaning, and there are certain practices which I will be telling in detail. So you have to remember the size of the virus is actually quite small. It's 0.06 to 0.14 microns. Just in comparison, the normal influenza virus is almost 10 times bigger. So when you talk about filtering the virus, we are really talking about much smaller filters, HEPA filters, and now even the masks you wear should be able to not penetrate through the these filters. And as I said, the mechanism is, in the theater, it is during aerosol generating procedures. It could be airborne, or the rest of the scenarios, it is person-to-person contact by droplet, and also fomites, that is the other objects in the operating theater. So when you set up a dedicated OT, it needs to be, the recommendation is it has to be a preferably negative pressure room. Not easy, very expensive. And the engineers whom we have consulted, almost, it costs a lot. So the management, especially with, most of the hospitals having a dip in their income, will find it very, very difficult to invest in a negative pressure theater. So what we do is you need to have a theater with a dedicated air conditioning. If you are in a very low resource setting, you select a room which has got a good ventilation, put a split AC and an exhaust, preferably in the topmost floor of the hospital, and you can do a COVID positive. No, it is a COVID positive theater, and it's quite safe. If you're a little bit, if your hospital has a little bit of resources, the usual positive pressure theater itself can be converted by increasing the number of air exchanges. So, usually, you keep it more than 20 or 25 per hour. So that way, you exchange, and though the air is recirculated, it comes through the HEPA filters, and therefore these virus particles will be filtered. So this is practically what is possible in most of the hospitals where you increase the number of air exchanges in normal theater. But if you have in a low resource setting, better to set up a room in your topmost floor with a split AC and shift your OT, COVID OT there. And you need to modify the OT to establish routes. So the COVID OT should be the nearest to the entrance so that the patients can go in and out and they don't contaminate the rest of the OT. And you need to determine the duration of surgery and be very careful about what disposables are required and stock them all inside the theater. It's not like normal surgeries where whenever disposable, the circulating nurse goes out of the room and gets it. Now, every time you open the room, there's a risk of infection to others. So it needs to be very well planned. And also, you have to plan ahead what type of post-operative ward, like I told in the triage, whether they need to go to the isolation ward or COVID positive ward or the normal ward, and you plan the transport before itself. And other important factor is you need to allow only dedicated and minimal staff in the OR. When I said dedicated staff, it starts from receiving the patient. So usually what will happen is there will be one nurse who receives the patient, and there will be a couple of people who will transport the patient in the OT, and then the scrub nurse will scrub in and the circulating nurse will come out, finish the surgery, and again there's another team will come and shift the patient out. The recovery nurse will look after the nurse, and then there is and then she shifts the patient out. There is a change of 4 to 5 staff for every patient. That's what we're used to. But what you have to do now is just assign 2 people, the scrub nurse, the circulating nurse with the technician, who will start from receiving the patient, taking the patient to OT, finishing the surgery, and then transporting the patient out. The same 2 or 3 people only will take care of that patient. This is because if at all, it's an emergency and that patient turns positive, you can easily identify who are the 3 people who are closely in association with the patient. But if you function as usual, the whole OT will be exposed, and you would not know who is exposed and who is not. So it's very, very important to do this manpower planning. So also nurses breaks, when they finish the shift, it is a habit that the other nurse will come and relieve them, not in a COVID. No, they have to finish that particular case and only then leave. And also trainees. We have postgraduates in our hospital. Usually, they will, whenever they finish the ward work, they will immediately, come to theater and walk into the theater to look at our surgery. Here, you don't allow them to come in. Only the dedicated trainee who is for that particular case will be allowed to come inside the OT. So you need to create dedicated routes. You also need to have donning and doffing stations inside the theater, just outside the operating room, special PPE storage and reuse areas. And after operating the patient, you need to flag the instruments used and inform the CSST so that they know that this has been used in a COVID positive patients. So a lot of things you need to put in place. And here is a very busy slide, but I just want you to just notice the first column. We talks about personnel, the route, the materials, the patient, the OR, and the devices. So what we need to do is, with the anesthetist, with the senior staff nurses and the surgeons, we all need to sit together and put this grid where you say, okay, what am I going to do the personnel? At the time of transfer, you can see the first row on top. At the time of transfer, what to do at the theater entrance, how is the OR should be set up, where are we going to, how are you going to give the anesthesia, how is the surgery going to be performed, how is the recovery. This is a one-time job. Okay, you sit with all the important people who take decisions and who can train the rest of the people and finish this off in one go. For example, if you look at the personnel, full PPE has to be worn throughout, and same personnel allocated to the single patient. Okay, and once the patient is inside, so these are all commandments which every patient every staff in the OT should know. And then route, you fix it, and then how the material is going to be supplied, and if at all you need more supplies in the middle of the surgery, how it is going to be supplied. You need to have staff who's wearing full PPE and then only going there to supply it. So like that patient gets directly transferred to the operating room, and what you do in the operating room likewise. Now I'm not going to go too much into detail, but you get an idea. So you need to look at all these personnel, route, material, patient, OR, and devices against various time phases of the patient care, from transfer in to transfer out. So you do it as a one-time job and get your SOPs ready and train each and every member of your operating theater. So staff safety is very important. I already touched upon PPE, and you need to train them. It is slightly different, wearing the full suit in the OT, because we wear sterile gowns. Therefore, the gowns won't be worn first. So, you need to train the theater personnel differently, and you need to have separate donning and doffing areas outside the theater. Already touched upon that. And if you're treating positive patients, again the gold standard is using a positive airway pressure respirator, but again it's very expensive. So you will do by wearing an N95 mask and a full suit and a double gloves. So that's about staff safety. So this is a picture showing PPE donning and doffing in the OR. And don't forget about PPE disposal. The present biomedical rules is every object which is used in the COVID on a COVID patient goes into a double yellow bag, and with a hazard sign printed on that. So this is again to minimize the contamination. So it all goes into one bag and you can dispose it. So as I said, this is the three main topics I wanted to discuss today: surgeon safety, patient safety, and OT safety. And I covered those. Now we'll quickly go into N95 uses, because a little bit of confusion, so we need to clear the air a bit. So first of all, when can I reuse N95 mask? So here is a quick algorithm. Was the procedure you were involved in aerosol generating procedure? Then you can't reuse it. Did you treat a COVID positive patient? Then you cannot reuse it. Is the mask soiled? Then you can't. And if the mask is ill-fitting, you want it for 2 or 3 times, and now the mask is loose, no. So if you have answered the question, all these 4 questions, the answer is no. It is not an AGP. It is not a COVID positive patient. The mask is not soiled and it is fitting well. Then only you can reuse the N95 mask. So please, make a note of these algorithm. It's it's very important. Now, having made the decision to reuse it, you need to decontaminate. How do you decontaminate it? In this juncture, I wanted to know. I'm sure many of you might have used this website. It's called N95 Decon. It's available. You just have to Google and see N95 Decon. It's a very easy name to remember. So it is a non-profit site, and they have compared all the different methods of decontamination against 4 criteria. I'll just tell about the criteria in the next slide. And they have given whether it is useful or not, or whether there is varying evidence on that. So green is useful, yellow is doubtful, and red is totally not acceptable. So it's a very useful resource. So now, according to this site, there are only these methods of decontamination are of any use: vaporized hydrogen peroxide gas plasma, UV either in a room or cabinet, and humid heat oven. So here, I'll just a little bit of thing about the UV. I did mention it earlier. So UV room or cabinet, the strength of the UV is very important. Most of the commercially available UV boxes, you don't even know what the strength is. So these criteria are available in the CDC website and several other websites. You have to make sure whatever the UV installation in your hospital is of the minimum strength to inactivate or deactivate this virus particle. So based each of these, you have to be. There are 4 things to be looked at: level of decontamination achieved, inactivation of the COVID-19 virus, and the effect of the filtration efficiency of the mask, and whether it leaves behind any chemical residue, in which case you need to have some other method of removing the chemical residue. So when you look at the methods which I said are useful, even these 4 or 5, you can see none of them is green throughout. If you see hydrogen peroxide, it is good for level of decontamination, viral inactivation. That's the first and second column. The third column, filtration efficiency, vaporized hydrogen peroxide is fine. But if you use plasma, then the filtration efficiency and the fit of the N95 mask goes down. Not really very badly, but it does compromise it. And both methods of hydrogen peroxide decontamination leaves chemical residue. Whereas if you see UV, the viral filtration and level decontamination is a little bit doubtful, but it does not have any effect on the filtration efficiency of the mask, and it does not leave any chemical residue. So you can see even the ones which are recommended and mostly used most in most hospitals is not 100% effective. So, and also there is a risk of chemical residue. And if you look at the other methods, like autoclaving and all those things, they're not of much use at all. So the best method seems to be just air drying and allowing enough time for the virus particles to get inactivated, which is about 72 hours, 3 days. So you can also, and by doing this, you can reuse the mask at least 5 times. That's what most of the evidence shows. And you can even extend the life of this mask by wearing a surgical mask on top of the N95 and a visor, so that it doesn't get contaminated too much, with dirt and other things. So if you do that by air drying, you can use the mask minimum 5 to 7 times. And you would have, and there are several schedules. All India Institute of Medical Sciences also came up with a schedule where you take up 5 masks and then keep using 5 to 7 masks, and you would put first mask on day 1, second mask on day 1, so that you give at least 3 to 5 days for each mask before they are worn. So that seems to be the cheapest and best method of decontaminating N95 mask. It is simple, but the only thing it needs a little bit of logistics and strategization. You can see here in one theater how they have made N95 mask hangers to be air dried. So you'd use something like that. So that's about N95 masks. Finally, a little bit of thing about each certain special procedures. So aerosol generating procedures, which the anesthesists do, is a risky procedure, giving general anesthesia. So it has to be done in a negative pressure room. So if you don't have a theater which is negative pressure, at least if you can make a negative pressure room where you can induce the patients, that's also okay. But even if that is not possible and you do it inside the theater, you need to have a mandatory waiting time. There is no science behind this waiting time. It's just logic, where you do an aerosol generating procedures, and if you have an air exchange of 20 to 25 times an hour, you expect the virus to be cleared in about 15 to 30 minutes. So several institutions have several guidelines starting from 10 minutes to 30 minutes. So we are somewhere in the 15 to 20 minutes. We wait for the air exchanges to take place, and the surgical team enters only after that. And during induction, only the anesthetic team is in the theater. So that's about aerosol generating procedures. We'll talk about other aerosol, like laparoscopic and orthopedic surgery in a bit. But before that, I'll talk about surgical smoke. The point to remember is, till today, there is no evidence that COVID-19 spreads due to surgical smoke. But there are several other viruses which have been shown to spread by this route. So we can't be sure. So therefore, to be on the safest side, we have to use the devices in the lowest setting. If you have, or you are lucky enough to have smoke extractors, use them. But most of us use these in a small suction tube, which is fixed along with the diathermy stick. And if that way, you can extract the smoke and it goes into a water seal. So that's one way you can it's again an innovation which can be done. Now, what about laparoscopic surgery? It has been proven that it is safe to do laparoscopic surgery, but there are certain things you have to keep in mind. You have to keep the incision small so that there's no leak around the ports, and you keep the CO2 insufflation pressure to the minimum. And another good practice is to fix all the trocars with a stitch so that you avoid accidental slippage. And when you want to release the pneumoperitoneum, you do it in a controlled manner through ultrafiltration systems. These are also available commercially, again, expensive. So what we do is we put it in a suction, and this goes under an underwater seal so that all this CO2 goes under the water, and then it is absorbed in the water. So CO2 is very dissolvable in water. So, and that is discarded separately. So there's another very important aspect, that open technique actually carries more risk in terms of the virus release, because the incisions are larger. In terms of safety for the patient, open method is better, but in terms of COVID-19 spread, open technique carries more risks. So it's a very tough choice. So finally, we'll just talk about orthopedic surgery, which involves use of saws and drills, suctions and irrigation. There's a lot of spray happening, but most orthopedic surgeons are already used to wearing protection for this. They're the ones who have been regularly wearing face protection, and I think most of the studies show that if you wear the face shield and the N95 mask, the risks are not same as any other surgery. Again, no clear evidence whether the virus in the blood or bone marrow or soft tissues will spread to the others, but still we are being on the safe side. And endoscopy also is an aerosol generating procedure. So you need to test like surgery. All patients should be tested prior to endoscopy unless it's an emergency. Appropriate PPE. Another very practical point is, if you've done endoscopy, you'll know that those caps and buttons, if you don't actually tighten them or close them properly, there can be leaks. So you make sure proactively that these are closed before you start the procedure. So it is, GA tract is a known place where the virus can be there, so you have to be careful. So prolonged procedures, where you do, mucosal resection surgery for CA, stomach and all that, better to avoid it, because it involves high pressure or gas inflow, and it's very difficult to prevent the spread of the virus in these sort of prolonged procedures. So we are almost at the end of my talk. I have covered surgeon safety, patient safety, OT safety, N95 reuse, and procedural safety. Finally, a little bit of word about what are the unique challenges that COVID-19 has thrown up. So the first thing is identity. I mean, I don't even know who my assistant is or who my scrub nurse is. So here you can see, a hospital has come up with a very unique practice of putting their photos and the names, in their scrub suit. So, you can't even, if you look at the pictures, can you think that the lady in the yellow suit in the middle is actually the one who's staring at you through the mask? I won't recognize her. So this is, very, very important. And communication also becomes a problem. Now we're facing every day. I ask for some instrument and say the scrub nurse gives me another instrument in my hand. I mean, because with the N95 mask and the visor, the communication is very, very difficult, and therefore there is potential for medical errors. Very important that we don't do wrong site surgery, wrong patient surgery, and therefore, the surgical safety checklist becomes very, very important, in the COVID-19 pandemic. So this is the usual surgical safety checklist. All of you, are familiar with that. But here is a surgical safety checklist for COVID-19 surgeries. So here you can see in the pre-operative, as I told you about, there is a team briefing. There is a, where the theater is set up, and then how we are also checking how the patient is going to be transported to the OR. And intraoperative, they're talking about PPE and induction during operation and end of the case, post-op, and after the patient leaves. So this is a very good checklist. It's available online in its site called Lifebox. You can search for COVID-19 surgical patient checklist. Google it, you'll get it. So I think that's all I wanted to say today for the surgical safety during the COVID-19 pandemic. Again, my apologies for being late, and I want to conclude saying that COVID-19 spreads very easily, but we tend to forget that it is also easy to prevent and stop the virus, because only three things: we need to perform hand hygiene, we need to wear the proper PPE, and we need to maintain the distance. If you're not able to maintain the distance, you need to have barriers from the virus. So I have told about the specific surgical safety precautions under the three headings of surgeon safety, patient safety, and OT safety. I hope it was useful. Thank you so much.
Thank you so much, sir, for your wonderful presentation. I think it was a very clear and precise presentation, very much on point, and it definitely addressed the need of the enhanced surgical safety that we require during the surgical procedures during this COVID-19 pandemic and how one has to prepare for it. But there are a few questions. Hope we have time to take them over here. This first question is a little bit off this thing. It's just that the question is being asked is that, can we use high resolution CT in case of emergency situation where RT-PCR is not available as a diagnostic modality for COVID-19 diagnosis?
I think you want to take it, Sajank?
Sir, okay.
Yeah.
Okay. So I know this is not the right question for sir, as not a diagnostician, but based on our previous experience, conclusively, as the guidelines say, RT-PCR is the one that he needs to take on board. But for high resolution CT to be used, there has to be some certain specific guidelines and other things. But a provisional diagnosis of COVID-19 can be made using high resolution CT, but not a final diagnosis.
Yeah, I think our emergency uses it.
Yeah,
because it takes RT-PCR 4 hours or sometimes even 6 hours to come.
Okay.
So they do use HRCT, but the diagnosis that's not the final diagnosis.
Correct. That's what
it helps in triaging the patient and putting them in appropriate beds.
Appropriate beds. Correct.
That's all you can do. But the gold standard as of today is the RT-PCR.
Still RT-PCR. Yeah. Okay. Right, sir. So the next question is that this is just a doubtful question that people are asking. You talked about having people kept in negative pressure rooms. The question is that, does negative pressure rooms increase the risk of SSI when we put them in negative pressure rooms?
Definitely. See, the whole history of surgery evolved from operating to normal rooms into positive pressure rooms, and it has been proven beyond doubt that SSI is decreased with the positive pressure room, especially in orthopedic surgery, and also using the HEPA filters along with the positive pressure rooms. So yes, it is that's why I feel without compromising on SSI, using more air exchanges seems to be the balanced approach to the COVID-19 pandemic.
Okay, so I would just like to add on to this question, the question that has been asked. So, as a surgeon and as a hospital that's operating, are there any engineering changes that need to be done if they have a HEPA filter and a centralized air conditioned OT?
Mainly the air handling unit, I think that's what needs to be enhanced. No,
Okay.
I think in our OT, if I remember, they have put an additional air handling, extra power,
Okay.
because it's very simple actually. My engineer explained to me. You are taking out it's like opening all the windows in your AC room.
Correct.
So you need more pressure to blow more air into the room. So they need a more higher power air handling unit. So that is an investment. I think it costs around 40 to 60,000 or something, depending on what the power you need to
Capacity
add.
of the
Capacity of that. So that is an engineering thing. But another innovation we did, because we have 3 theaters in a row, and we have a common corridor. So what we did is we put high-powered exhausts in that corridor. It's a semi-sterile corridor between it, and then there is a recovery and other things on the other side of the theater. So after induction or after recovery, there's a no entry board, and the high-powered exhausts run for about 15-20 minutes. The OT, doors are open, and so that also was an engineering thing which we made. So though we didn't make it negative pressure theater, we made the corridor negative pressure.
Okay, right. So this is maybe a repeat question that is there. N95 mask, is it compulsory or mandatory in the OR? Do you think N95 mask should be worn for surgical cases for COVID
in the
positive
ward
cases?
Or in the OT?
In the OR, sir, in the operating.
OR, yes, there's no doubt about that.
Okay, so as we said,
the reason is, as I said, we don't know whether the COVID negative patients is actually COVID negative.
Okay.
There's a small risk of your COVID negative patient also being positive, because RT-PCR is sensitivity, the accuracy is only about 80%.
Okay.
So that's the reason.
So as we said, all of them should be wearing N95 mask, and if preferably the core surgical team should be wearing powered air purifier. That will be a more ideal scenario.
That's ideal. Yeah.
Ideal. Okay. So this is a two-part question, sir. The question says that do all the personnel who are in the OR, should they wear PPE? Second thing, then if yes, then how will you take care of scrubbing before the surgery? So basically, it's a two-part question. How do you handle scrubbing, and how do you make sure that everyone wears the PPE?
As I said, there are two levels. One is, the enhanced standard precautions, where normally in a theater, all of us will be wearing, the scrubs, and we will wear a cap and a normal surgical mask.
Okay.
So in the COVID-19, the enhanced thing is all of us wear the N95 mask.
Okay.
Otherwise, it's people are in the recovery and all that. That's the only difference. Whereas people who are in close contact, see, the other thing which you have to also remember, the risk of infection depends on the time of your contact. It's been clearly shown, if it is less than 15 minutes, your chances are low. Whereas if it's more than 15 minutes, your chances are high. So anybody who is doing patient care for more than 15 minutes, that is the recovery nurse or the nurse who receives, also wears a visor in front of the N95 mask, but not a scrub, not a full scrub. You only wear the scrubs, not the gown.
Okay. So that means before the surgery, once the patient moves into the theater, that's when you wear all of this enhanced PPE and then scrub and then go into
That's why I said you need to have a donning and doffing outside each operating room.
Right.
So where you have all the PPE stored there, and then you put everything, the additional gown and the face protection and everything, the full suit, and then you go inside the theater. Okay. I hope that answered both the questions.
Okay. So just to add another point to this thing is, please note that usually most suppliers, when they provide you PPE kits, they are unsterile. They're only clean kits. So it is always better that you ETO sterile them and then use them before you go it for the theater, or you ask them to give it ETO sterilized and then give them the PPE kits for surgery.
That's a very important point. I'm glad you brought it up.
Okay. Yeah. Sir, just a question. This came because after handling the case, this is probably one area that we probably should have looked at is what should be the chemicals that we should use for cleaning the theater after a COVID-19 case has been done, sir? Any special recommendations?
See, as far as COVID-19, no, it's actually a cheap virus.
Okay.
Right?
Yeah.
All you need is a mask, your hand hygiene, and keep the distance.
Yeah.
And for disinfection, 1% sodium hypochlorite is enough. And for the hand hygiene, now you only need soap and water.
Okay.
Right? It's a fat molecule, so anything which has got soap will dissolve it.
Yeah.
And in the theater or any the surface disinfection, 1% sodium hypochlorite is cheap, but it needs to be freshly prepared.
Correct.
It needs to be freshly prepared and used. It's enough. I mean, you don't need to. But of course, there are several commercial products which are available, which are very effective against these viruses.
Okay.
I don't know the names. I think Seshank may be knowing them better.
Sir, if you want to give this thing, actually our own sponsor Schulke themselves make a NADCC tablet. That's the sodium hypochlorite tablet, which is readily dissolvable. So you can store it for a longer time, unlike the concentrate solution, which you have to prepare every few days. So this can be directly mixed a number of tablets in a particular 1 liter of water or 10 liters of water, and then used freshly over there, as and when they're disinfecting the theaters. But just a note, sir, one has to also be very mindful that whenever using hypochlorite, this should be only used on the floors and the walls, and make sure that there is no leaching that is occurring because of the high concentration of chlorine which is being used. While the instruments and other things should be like the anesthesia equipment and the other things, the other parts should be disinfected using 70% alcohol, not sodium hypochlorite. Including the laparoscopic.
To be more specific, this is only for surfaces.
Correct. Yeah. Just we wanted to
1% hypochlorite is only for
surfaces.
Yes. Yeah, okay. That's correct.
Correct. Yeah. So the next question is that you talked about having a negative pressure room before while intubating. So one question they thought was, can we switch off the air conditioning before when the intubation is going on, and then switch it on after that? Would that help in the theater if they don't have a negative pressure room?
Oh, actually, switching it off will not help. See, the thing is, if you don't have a negative pressure theater, the best option is increasing the the air cycles, return of air at more than 25 per hour. And the other thing which you could do is put an exhaust, and to vent the air while you're doing the AGP. So it's but with just not having the AC, there's no ventilation. If you have a theater which has got at least an exhaust fan to the outside, you switch it on. But the problem is, if you have the theater in the ground floor, and you switch on the exhaust fan, it's going to blow on people who are walking on the road. So that's the reason. Either you need to have a duct which vents the exhaust, to your terrace, or if you have a room in your topmost floor, you can use it.
Okay.
But I don't think just stopping the AC is going to help.
Okay. So this question is not completely clear by Parthibadan Dangol, but he's saying, question is there any change that one needs to do among the suggestion that you have suggested for anyone who's doing an open heart surgery, like for the cardiac team? Is there any change in safety precautions?
No idea. I don't do it, so I'm sorry.
Okay. So as Sir mentioned, I'm just going to extrapolate from what Sir mentioned to this question, is that laparoscopic or keyhole or minimal hole procedures are a lot more safer compared to open heart procedures, open procedures. Open procedures, one has to take more enhanced precautions when handling it. So that's the reason why you need to be using something like a power air purifier when you're handling such kind of cases. But you also have to make sure that those powered air purifiers that you're using are also compatible with the microscopic lenses that you're using for doing the procedure. Okay, so this is more of a general question, sir. Is N95 mask mandatory when you're handling non-COVID patients, like let's say in the OPD or anywhere when you don't know the status?
Sorry, Shashank, you're breaking up a bit.
Sorry, sir. The question was that is N95 mask mandatory for non-COVID patients, like when you're handling them in the OPD?
OPD, I think, see, the thing is, I'll tell you something. In the last 2 months, I have cancelled at least 10 patients.
Oh,
whom I have posted for elective surgery. And then when we tested, they came into my room. I examined them. Now some of them had a hernia, some of them had fistula, soft tissue, tumors and all that. And then when I decided on surgeries and posted them and tested for RT-PCR, they turned out positive.
okay.
10, my number is 10, and along with my colleagues, we have almost 30 in the last 2 to 3 months. They're all completely asymptomatic, and they turn out to be positive. So I was actually wearing a surgical mask and a visor before this, and now I have converted to N95 and a visor. So it's not recommended by CDC or ICMR or WHO, because they say surgical mask with a visor is more than sufficient for outpatient setting. So if you go by recommendations, yes, you don't need it. But from a personal experience and also my colleagues, several of my colleagues, not only in my hospital, there are several, asymptomatic patients seems to be more than actually the symptomatic patients.
Okay.
So, and again, it is the length of exposure. Cumulatively, if you see in an OP, if I see 10 patients, and even if I spend 3 minutes for each one of them, I have spent 30 minutes with patients. So you can imagine, the contact time with patients goes up. So I think, for healthcare, especially if you are constantly, it doesn't matter if you're just a helping person who's just coming in and out of the room. My nursing assistants just come, when I'm doing a rectal exam and then they go out. But I'm in the room, I'm in contact with the patient for 10 patients is minimum. So if it's more than that, contact time is more. So the risk is also more. Okay. So that's the reason I prefer to use N95. It's a very personal choice.
Correct, sir.
Not backed by guidelines.
I understood. It's more of a psychology, more of a psyche thing that matters when you're dealing with such cases. True. So just a quick question. This is a question that is again out of your purview, but just if you would like to throw some light on it. Do you do the rapid antigen test in your hospital, sir, just in case of emergencies?
Yeah, we do that. But again, the government recommendation, it has to be backed up by the RT-PCR.
RT-PCR. So again,
being a private hospital, it becomes very expensive for the patient. We started doing, but then we gave it up because that costs almost equivalent to the RT-PCR, a little bit less. But cumulatively, it almost doubles the cost for the patient.
Correct.
So we are a cost-conscious hospital, so we dropped that. We only do RT-PCR.
Okay, sure. So this is the question again. People are asking: is surgical mask sufficient or not during orthopedic surgery? So to answer this question again, we are repeating it.
There is no brainer. Surgery, when you're doing surgery, especially orthopedic surgery, again, there is no evidence that the virus is transmitted in these aerosols, the drilling thing and all this irrigation and all that.
Correct.
But 3 months down the line, COVID-19, the evidence is changing every day. So, and there has been experience of virus being transmitted in these, aerosols even before.
Right.
So, I think for surgery, especially orthopedic surgery, where there's a lot of aerosol exposure, N95 mask with a visor.
With a visor. Okay.
Yes.
Thank you, sir. Thank you so much for those questions. So we will stop the questions at this point. We've already exceeded the time a little more since we started a little bit late. I would like to thank Dr. Parivallavan for his wonderful talk and discussion today. So we would like to thank you, sir. Thank you so much for your time. I know despite your emergency, you were here today. We hope everything goes well and your family recovers.
Thank you.
We wish you well for it. So before people leave, I would just like to say that there are different programs that are currently available. Schulke, along with IBHAR, is providing certain programs where they come into your hospital. When you contact them, they'll do an assessment using an online tool, so you can know whether your hospital is COVID ready or not. That is there. Second thing is that this is a 4-part webinar series that we have started. We did the first one in September 26th. This is the second one that's happening. The next one is happening in November, and the fourth one is happening in December, all on the theme of COVID-19 and different aspects that are there. So the next program is happening where we are talking about special circumstances other than the surgical OT, like the cath lab, the labor room, and other places, and endoscopy and bronchoscopy, how you'll deal with that. So we are going to be having a session on that. So we request all the participants who are there to kindly attend all the sessions, and there will be a feedback link that will be sent to you tomorrow on your email. So kindly check on that link. Please complete the feedback. And all the participants who attend all the 4 programs will also be provided an e-certificate for attending this program. So kindly do that. And other thing is that we are also coming up with an international infection control program that is coming up very soon. And even Dr. Parivalvan at his Skills for Med Center does infection control program and other training programs for nurses and paramedics. So if anybody is interested, please get in touch with us. We'll get you in contact with sir and even with our own international infection control program. So with that, I would like to say thank you so much. Thank you again, sir, for your presence over here. Wonderful session it was.
Thank you.
Thank you. We would like to thank our supports today from SATS Academy and also for Schulke for sponsoring this session. Thank you so much for everyone. Good day and good evening to all. Thank you.
Thank you.